Thank you for being here on behalf of the Renal Pathology Society Education and Training Committee. It's my pleasure to welcome everyone and to briefly introduce our speaker today, Dr. Jeffrey Miner.
So thank you, Dr. Kung, for that kind introduction and for the invitation to present to you all. It's great to see a crowd on a Sunday morning. My title slide and the title that was given to me was Alport Kidney Disease Spectrum. Um, and I'll note that I am a PhD scientist, but I'll do my best to be correct when I talk about clinical issues. I've focused on the glomerular basement membrane for about 30 years now, or just over 30 years, at WashU in St. Louis. And this title, Alport Kidney Disease Spectrum, is great. I love the colorfulness of it. Uh, and there's, as you'll see later, there's a conversation going on amongst nephrologists and patients that have Alport syndrome and related diseases, and researchers like myself about kind of reclassifying patients based on genetics and symptoms and how they should be or what the overall disease should be called. And patients in the US don't like the word spectrum because they think it implies autism spectrum disorder. I had come up with a term I thought was perfect. Alport Alport kidney disease spectrum. Actually, this is a good one, but there was another one, Alport spectrum disorder. Um, Patients want to have the word Alport in their disease because they've come to identify with it over the years. um, so I'll talk more about that later. Let's see if I can actually go to the next slide. So I did kind of change my title to the Continuum of Alport syndrome and related kidney diseases. Continuum is basically similar to spectrum, but without that autism um, caveat. And so I'll give you the take-home message first. Alport syndrome is now recognized to be a genetically complex disease spectrum that varies from mild, which includes hematuria with no progression further than that, to severe, with kidney failure and the typical hearing and eye abnormalities that are characteristic of the severe syndromic version of the disease. Based on genetics, and this is very surprising, 1% of the population carries a variant in a collagen 4 gene that can cause hematuria and slightly increases the risk of CKD. So here are some disclosures. I won't really be talking about any sort of treatments, so none of these are really relevant to my talk. At least I won't be talking about treatments in detail. But I wanted to start with the history of Alport syndrome. I'm kind of a history trivia buff, so I was really interested to explore how Alport syndrome came to be. And in 1927, almost 100 years ago, Dr. Cecil Alport published in the British Medical Journal this paper about hereditary familial or congenital nephritis, which he determined is a definite entity. And he said that the kidneys in these patients are more susceptible to damage by the toxin of an unknown organism than is the case in the normal person. Many patients were noted to be stone deaf in this paper. So Dr. Alport realized that there was some sort of hereditary susceptibility to kidney disease, but I think because of what was going on in medicine at the time, where there were so many infections going on in the population that would then lead to kidney disease, and maybe some of you can explain it better than I can, that he was assuming that basically glomerular disease was caused by an infection and that patients with Alport syndrome were simply more susceptible to damage by this whatever infectious organism it might be. He didn't really consider that it could just be a genetic cause would be due to a structural or functional defect in the kidney itself. Then 34 years later, Williamson published in The Lancet the first naming of this disease as Alport syndrome, hereditary nephritis with deafness. So he suggested that the syndrome of hereditary nephritis associated with deafness should be known as Alport syndrome. this syndrome may be less uncommon than is supposed, and sporadic cases may occur. So Dr. Williamson was 100% correct in that aspect. Alport syndrome is less uncommon or more common than was initially thought. In fact, when I started my lab at WashU in 1996, I went from a basic science department where I was studying basement membranes intently to the division of nephrology, where the nephrologist there told me I was studying an interesting problem. Everyone had heard of Alport syndrome, but they never saw patients with Alport syndrome. I think now that we know a lot more about it, at the time, they had patients that had a form of Alport syndrome in the dialysis clinic that they didn't realize actually had a collagen 4 related disease. And I saw there were some maybe comments in the chat. Was there something for me to answer there?
No, not yet.
Okay, great. So, sorry, I'm having trouble with my slides. Okay, so I don't really need to introduce the nephron to you all, I hope. We're focusing on the glomerulus. And I did want to show something you may not have seen before is glomerular filtration in action. So on the right will be a movie made at the University of Indiana, I believe by Bruce Molitoris' group when he was still there. Um, and they basically injected fluorescent dyes into the vein of a rat, and they had exposed the kidney and were viewing it under a multiphoton microscope where they could see rather at least tens of microns below the surface of the kidney. And they injected fluorescent dyes into the rat vasculature. The large dye was yellow and the small dye was red. And so as you watch the movie, you can see that immediately the glomerular capillaries become visible. The dark spots are red blood cells that don't fluoresce, but you're seeing the yellow fluorescence in the glomerular capillaries as well as in the intertubular capillaries. And rather quickly, the red dye enters Bowman space and then goes down the tubule. And that's because the yellow dye is maintained in the vasculature because it's larger, and the red one is filtered easily because it's smaller. And this demonstrates glomerular perm selectivity. This perm selectivity is diminished in